right, who's recording?
Cat.
Lights, camera.
I'm assuming you're signing.
Action.
Go.
58-year-old male self-referred to clinic with primary complaint of right anterior lateral hip pain. He has seen an orthopedist in the past month who feels that THA is in this patient's future, but both would like to try conservative treatment at this point in time. He experiences pain each morning when getting out of bed and intermittent hip pain that is aggravated by squatting, going upstairs, hip rotation during weight-bearing activities. The pain is kept him from his regular gym activities, treadmill, and weightlifting. His goal is to return to a previous level of function during gym and ADLs.
All right, what do you guys think it is?
Right hip away.
Hip osteoarthritis. Okay, how is this patient's age relevant to the diagnosis?
This diagnosis is most common in adults over 50.
And how old am I?
Uh-oh. Not a day over 25.
49.
Am I right?
50.
49
I'm
and a half.
50. According to right, exactly. Patient is older than 50. Okay, what are some causes that, if you're looking at an X-ray, what are some things you'd see on an X-ray for this diagnosis?
The joint space would be narrowing and you have some osteophyte growth.
Well, that's the reason for the joint space narrow, right? Yes, and what else? What's narrowing the joint space besides the osteophyte?
There's wearing down of the capsule,
Start with a C.
Cartilage.
Cartilage. Yeah. Nice. Yes. So defective integrity of the articular cartilage and decreased bone and joint margins. Very good. What are two possible sets of criteria according to the American Rheumatology Association, which Gus is a member?
Indeed.
What are the criteria?
Over 50 years old and morning stiffness under 60 minutes.
So over 50 years old, what else? There's two range of motions that I'm looking for specifically.
Internal rotation,
Is what?
internal rotation less than 15 degrees.
Uh-huh.
And flexion less than 115.
That's one set of criteria. Older than 50, internal rotation is less than 15 degrees, flexion is less than 115. Or
IR is
Less than 15 degrees.
is more than 15
more,
degrees.
but with pain.
Right, so internal rotation is more than 15 degrees, but painful and
Morning stiffness that lasts over an hour.
about less than an hour.
Less than an hour.
Do I need to repeat this?
Internal rotation over 15 degrees, but there is pain.
Yes.
Stiffness in the morning that lasts under an hour.
That resolves itself in under an hour. Good. What activities or movements would increase this patient's pain? Pain during?
squatting, stair climbing,
Uh-huh.
turning, and prolonged sitting.
Yes. So anything else?
Walking.
Ambulation, right? Very good. Right? You're gonna look for altered gait patterns possibly to avoid pain. Squatting or stair climbing, you said. Sitting for too much, because when the hip is in more than 90 degrees of flexion, what is it doing to the joint? Yes, and we sit usually at least in 90 degrees of flexion, especially if you guys taught the person how to sit, right, way back when. Then that's gonna be very painful. And AM pain is worse than PM pain, because that is a classic sign. You wake up, like you mentioned, morning stiffness. Yes, classic. All right, I just said it already, but I'll ask it again. Time of day the patient might feel more pain?
Morning, patient has not moved all night. Movement provides relief from OA symptoms. They can be one of the classic symptoms of OA is morning stiffness that resolves within an hour.
Saying it fast does not make up for all the mistakes you make.
All I wrote was that.
Thank you.
Yeah.
Yes, morning stiffness or pain, but like you said, when you move, you're moving synovial fluid, so eventually it starts feeling better, so in about 60 minutes, okay? That is a classic sign, not just of hip osteoarthritis, but any osteoarthritis. All right, assessment. Like I said thousands of times, you will be responsible to do goniometry and manual muscle testing for the practical. I'll say it again. There's no more excuses, oh, we didn't learn that. You definitely learned hip, knee, and ankle. So there goes, there's no more, I mean, not excuses. I understand you didn't learn the hands. I didn't ask the hands. But the hip, knee, and ankle, you'll be responsible. We're not gonna spend time showing it now because you should review and know how to do goniometry, right? Especially in the right patient position. We had some doozies in the first practical that will not happen again for the second practical. Okay.
Says you.
So speaking of manual muscle testing, but you'll have to do it for the practical. We're not gonna do it exactly right now because you learned this already. You can review it with yourself and partners. What is weak? What range of motions are weak?
The hip abductors,
Abduction,
extension,
extension,
and external.
that is
rotation.
correct, very good. That's manual muscle testing. When you do an active strength testing, show us one standing and one ambulation test that will show hip musculature weakness.
So for standing, we said single leg stance to test hip abduction strength.
And that is called what? The Trendelenburg test, right? And can you show us what, how this works? You have the patient do what?
Okay, so I have a patient stand on one leg.
Uh-huh. If they're
And-
staying on their left leg and their right leg,
So sitting on the right leg and the left hip drops, then her right glute med is weak.
that is right. Right glute med weakness when the left hip drops. If you don't do a standing test, you do an ambulation test, it's the same thing. You have the patient walk and you look for that dropping. It will look nothing like that. But yes, you will see a drop of the opposite leg when the affected leg is in single leg stance. Okay? Any questions on that? Make sense to everybody? Excellent. So that's a Trendelenburg test in standing, or the Trendelenburg gait assessments. Very good. Range of motion testing. What specific range of motions will be limited?
Hip extension, hip external rotation, hip flexion, and hip internal rotation.
That is right. Extension, external rotation, flexion, and internal rotation will all be limited in range of motion, so you should know how to do all of those. What capsular, when you test the capsular integrity, what parts of the hip capsule are limited?
Anterior and posterior.
The anterior and posterior capsules are limited. Very good. Now for endurance testing. Why? The patient's hip is hurting, they are not moving. When you ask them to walk, they are limited by pain in this case, right? What test will you use?
The 6-minute walk test.
The 6-minute walk test.
6
Okay.
minutes.
It's for
Where-
6 minutes. Well, if the patient can tolerate 6 minutes, how do you set it up? You take 2 cones, how far apart?
90 feet, 30 meters.
30 meters apart, and you have the patient walk around the cones in a circular movement, right? While you're timing them for 6 minutes, obviously, and how many steps. If you know exactly how far apart, you can tell how many steps they've walked. Either they will not be able to walk the full 6 minutes because of hip pain, and then you record how many steps they took and how many minutes they were able to walk, or they go the full 6 minutes, but they're doing it very slowly because of pain, and they'll be behind the standard deviations of what's normal for their age group. You got that? Okay, and it's a good barometer, first, to show that they have issues. Second, as you get them stronger, they can walk more and tolerate more. All right, now let's talk about the other special tests, shall we? Are we using this table? Sure.
Sure.
What are some special tests you will use to rule in your diagnosis of hip osteoarthritis?
I can do the second one.
Who's the patient? Who's the PTA?
Dave, I don't know.
First, we're gonna do the Faber test.
Okay, the
So-
patient is in supine.
Supine. Bring your left side out straight.
It's a passive test. Do it on the patient.
Oh, okay, all right. So, we're gonna bring you across here, here.
Good. Flexion, abduction, and external rotation,
External
right?
Rotation, pressure here, and.
Why is your left hand doing? Why are you putting?
Stabilizing the pelvis
For what purpose?
to make sure it doesn't come up.
Very good. And you pushing straight down.
Pushing
A
straight
positive
down.
sign is what?
Pain,
Where?
posterior,
Posterior hip or posterior or anterior hip is a sign of hip osteoarthritis. What if they have pain in the SI joint?
pain in
So they might have SI joint dysfunction as opposed to hip osteoarthritis. That is the favorite test. Very good. What's the next test you're going to do?
The shear.
the.
There's the lids of the thumb one. Sorry, excuse me, scour.
I was about to say this is the wrong diagnosis.
Sorry,
Yes.
sorry.
Scour test, also called the quadrant test.
We're gonna go over 90 degrees of
Get on the table, please.
flexion.
Good. On the table. There we
I'm up.
go. Yeah. 90-90, hip 90,
Flexion, a little bit of AD, and sorry.
hip flexion, knee flexion, and you are doing what?
And now from here, we're pressing
It's
down.
pressing down while you're doing what?
Bringing to AB.
So you either go to AB or adduction while you're pushing down,
Kind of just looking
or you could do external and internal rotation while you're pushing down.
And
See
positive
that?
sign is gonna be
Pain where?
Anterior.
Anterior or posterior hip will be pain because you're literally grinding the joint, just like with the CMC osteoarthritis. What is the third test?
The 30-second chair stay.
How does that go?
Perform as many sit to stand reps from a chair in
Who
30
is the
seconds.
PTA? Who is the patient?
Or your stance.
Do both.
Who is the PTA? Who's the patient? How should the patient's hands be?
Across the chest.
Patient across the chest. The seat should be what kind of chair?
One without wheels.
A one without wheels and 17 inches. Patient's arms are across the chest like so. And you're telling the patient to stand up and sit down for 30 seconds while the therapist
No.
go. Right. And there's a chart which I would definitely recommend you know what is the normal standard deviations of what is a normal amount, right? If the person does less than a certain amount, that is a sign that, and there's pain in the anterior and posterior hip, that is a sign that they have hip osteoarthritis, because again, flexion is the most painful experience for this patient. Red flag, tell me about the sign of the buttocks. It's not a tattoo.
Sign of the buttock is made of 7 signs that can indicate serious posterior issues posterior to the axis of flexion and extension of the hip. Signs of tension deficit suggest damage to the central nervous system. Test is positive, they may be able to identify capsular hip or pelvic disease. Primary sign is limited passive hip flexion and more painful, which is more painful than a straight leg raise. How'd that sound?
Sounded like whoever wrote the book did a great job. So basically, the patient complains of hip pain, right? And you think, oh, it's probably, who knows, hip osteoarthritis, whatever. It can be a massive degeneration of the area, or it could be a tumor. And the positive sign for that is if it hurts with passive range, and even very little passive range. So if the patient is lying supine and you do passive hip flexion, okay, we're good so far? And 60 degrees, they say, I can't go anymore. Well, that's tight hamstrings, right? But if you go up 20 degrees or 10 degrees and they're in a lot of pain in the butt, you're like, well, that's something serious. Why do they have so much pain with limited range, right? So if there's SI joint dysfunction at 60 or better, or there's hamstring tightness at 60 or better, that's normal. But if you just raise the patient's leg passively 20 degrees, it can be severe hip damage or a tumor. And in that case, you must refer them to a doctor because you might worry that it's something else. You don't tell the patient, oh, you might have a tumor, young lady. No. You say, you know what, great. You call the doctor and say, hey, I'm noticing this. What should I do? Does that make sense, everybody? That's the sign of the buttocks. Good. Now our favorite modalities. Patient has pain in the posterior hip. How would you set the parameters for pain control?
We say IFC,
IFC, how many pads?
4.
4 pads, 2 channels. You increase the,
Frequency, we say 2500.
you don't have to memorize frequency, Francis. You never did. What do you raise the intensity to?
Comfortable tingling.
Comfortable tingling. And by the way, it's either 4,500 or 5,000. That's not relevant. Comfortable tingling because it's pain control, right? Excellent. We don't like taking off points for eSTEM questions, especially when we tell you exactly what we're going to ask you. But we had to do it a few times. Why? Just don't look at me. I'm not talking about you.
What?
You give me the look like I didn't mean no.
You
People,
good.
I don't remember who it was even, but why? Why do it? No. Okay, now we're up to treatment. Okay, treatment.
I don't like laser.
Yeah, I just simply want to
All right, let's. How would you stretch the tight musculature discussed early on?
The piriformis stretch,
Show
lunge
it,
stretch,
show it.
and butterfly. First one could be as simple as just seated and figure 4, placing the leg, ankle over knee, and just kind of bending from the hip. It could be in supine, same idea. Lunge would be like on the table.
So that's the hip external rotation for the patient itself. A lunge stretch for the hip flexors, good. And what else?
And then a butterfly stretch.
Wait, go back into it.
Which hip are you stretching?
He's stretching. He's stretching the right. Don't lunge. Upright. Squeeze your glutes. Where do you feel the stretch?
Nowhere.
Nowhere. All right. Now gently lean forward.
Forward.
Through the
No,
lunge.
with your hip. Hips drive.
I follow the directions very well.
Put your right arm.
Wave at the queen.
I felt it.
I don't believe it.
So he's stretching his right hip flexor. You do not want him to have a flexed lumbar spine because that will put the hip flexor on stretch, right? Squeezing the glutes and having a non-flexed lumbar spine, as Carlos was trying to show you, is really gets the hip flexor stretched.
Oh, don't do this.
Good. Very good. So we have the external rotation is the crossover thing you just showed us. The butterflies you're about to show us is for what?
The AD.
But adductors aren't tight in this diagnosis. Are they? It's AB extension and external rotation.
You stretch the adductors to improve abduction, no?
No, we're saying what is tight? What range of motion is limited? So you're stretching your, wait, I thought you guys said extension is limited, external rotation, flexion, and internal rotation.
Figure 4.
That was, we
That's
started
not,
that one.
that's figure
No, one where you pull it.
That's
too.
for external
four. That's
rotation.
still a figure four.
It's the same thing.
Is butterfly the external?
It's more adductors.
Yeah.
But we're good with what you showed us because really, when you stretch your hip internal rotators, they're really your external rotators.
Happy
So
day.
we're fine with that. Yes.
Happy day.
Okay. Where are we at now? And how would you stretch the patient on that? All those. You need a patient. So we want to see hip external rotation stretching, hip
Hip
stretching of your hip flexors, your external rotators, and what was the last one?
Adductors.
Oh,
Butterfly stretch. Adductors.
And the cross is for the wolf.
Okay.
Oh, he says, Jesus.
How would you stretch your hip extensors?
How rude.
Hip flexors, rather?
Oh.
Tom-
This one?
Thomas test. Thomas test. Thomas test. Yes.
Yeah.
No. Have her slide down. Thomas
Have her
test.
hold her own
Bring your
right
bottom
leg.
to the edge.
I'm pobrecito. Oh, jeez.
Grab. Push. Gently.
Oh, yeah, I did this to Eric. There's a picture of me doing that.
This is in the handout, right? This is in the stretching handout.
No.
Right?
Yeah.
Remember this?
Yeah.
I remember it. Or you could have the patient prone and you do the one with the knee off the table and.
It's more muscle.
I'm just saying. Okay, good. Now for strengthening. We are gonna strengthen what now and how are we gonna do it? Teach the patient. Abduction, extension, and external rotation. How are you gonna strengthen the patient? So the first level is non-weight bearing on the table, right?
Yeah.
So-
Side lying.
Face the audience.
Oh, hey.
Abduction.
Hey.
Abduction. Okay, I'll buy that. What's next?
What's next? Oh, we had a short arm quad.
You need a foam roll?
For what?
Oh, jeez. Careful with that thing.
For extension?
Yeah.
All right.
What are you doing?
Legs up.
Oh, okay.
All right.
Alright, press the knees. So, squeeze the thigh, lift your foot up to the ceiling, keep your knee on the bolster. Up and back down.
Works for me. Works for me. I'm not saying no.
Okay.
And then finally, external rotation. Non-weight bearing on the table.
Oh, not just. Okay. Yeah, just bend your knees a little more. Just keep your feet together, with this knee up to the ceiling.
Excellent. That's strengthening external rotation. Good. The joint mobs. early on you're gonna do grades 1 and 2 because the patient right now is limited by pain. What direction are you doing the mobs?
Posterior glide.
Posterior glide and
Anterior glide
anterior glide, because there's tightness in both of the capsule. Not to necessarily improve a range of motion, but there's tightness in the capsules, grade 1s and 2s. Again, please go back to the module to know how to do a hip posterior glide and a hip anterior glide. We had to take up points on some people because they didn't know how to do joint mobs when we learned how to do them. Okay? Thank you.
Yep.
That's phase 1. Initiate a walking program for cardiovascular fitness. What are some simple tips to give a patient who's never been on an elliptical machine to give them?
Start by facing the console. You get the motion by pushing the pedals in a forward motion while also pushing and pulling the handles evenly. Keep the heels pressed back into the pressed into the back of the foot plates.
My favorite is face the console. You never know
I
what
thought he was
person
gonna
knows.
stop at
Have
start.
you seen some people?
When you said start, I
can
thought you
only
were gonna
ima-
stop
I can
there.
only imagine. I can only imagine. All right.
Press the start button.
For the beginning.
Good.
No more than
Quickly
4.
describe the rate of perceived exertion. What is that?
It should feel.
But what is the rate of, what is that?
It's like a scale for how difficult.
Yes, so it's really up to a rate of perceived exertion is up to the patient, right?
It's that Borg.
It's subjective, but you explain to them if it's a beginner, what number are we talking
So
about?
we said 2 to 3, no more than 4. It should feel relatively easy, and as though the patient is
That is
able
right.
to-
So if you give them a scale of rate of perceived exertion, it should be easy. This is the beginner. Very good. All right. How would your patient properly use a cane? Same or opposite extremity?
The room about to divide again.
Ipsilateral or contralateral, right? The cane is held in the opposite extremity, right? And then you want to show you're good, guys, how to do it, right? Affected foot and cane come together, and then the unaffected foot moves forward,
Is
right?
that 4 point or 3 point or 2 point?
Yeah.
All right.
Preferably 2.
We went over.
I always
yes,
think of
we're going
the-
to modalities. All right, phase 2.
That was rough.
Teach your patient what are the more aggressive versions of the fate of this stretching?
So the pigeon, a weighted butterfly.
Show us the pigeon.
And a deep lunge with a twist.
So this pigeon will be the advancement of crossing one leg and going like this, right? Put the camera here. This is what they showed for the first one. This is an advancement of the first one, pigeon pose.
Oh
Pigeon
jeez.
pose.
This is the most stretched I've ever seen him.
This is the best patient ever. He goes from this to pigeon pose in 2 days.
What if they can't do that?
That's good. That
Yoga
works.
blocks. Yoga blocks
have
underneath the
them be
hip.
more up.
Which one?
That's good. All
The
right.
one- the
and
one
what
in front?
about hip extensor, hip flexors? What's an advanced? You did a lunge on the table. What's the advanced version?
No, what is this called?
The greatest stretch ever.
That's right.
What?
Look it
It's
up.
a
Look up the
lunge.
great.
Oh yeah,
I believe
that's
you
right.
do it
I remember
with
that.
your stretch there.
You had me do that
Look it
once.
up.
So now we're doing with a twist.
Get all angles. Oh, look at that skin.
That's good. What was, yeah. Okay, good. And finally, what is it? Am I missing one? Hamstrings?
We said
No, not hamstrings.
pumps or weights on the.
Extensors?
Okay. Now joint mobs are the same. They are grades 3 and 4 this time of anterior and posterior glides, right? Walking protocol. Tell me something about the treadmill.
When using the treadmill, be sure to use an emergency kill switch. Hold onto the handlebars at all times. For an intermediate walker, keep the pace under 5 miles per hour. One can use the heart rate monitor, keep an eye on the RPE. RPE should be kept between 4 and 6. They should be able to hold a short conversation but be breathing heavier.
So beginner rated perceived excursion is not above 4, and for intermediate it's not more than 6. Very good. Now they have to carry them groceries 2 blocks from the store. What is your advice to them?
To carry the bags on the right side, so the same
If it's a
side.
right
Yeah.
hip
Carry
osteoarthritis,
the bags
same
on the
side.
and
Ipsilateral.
the
Yeah.
left hand hold the cane.
Good, very good. So bags on the same side, cane on the opposite side. Very
Got
good.
that bag on me.
The patient has to lift boxes from the floor 3 to 4 times daily. What some advice you could give me when they're performing this task? And it can't be ask your strong nephew to do it or niece.
It's a wide base of support. Lift with 2 hands. Keep the
Okay.
boxes close to your body and avoid twisting at the trunk and holding.
I like it. Or I would say purchase something like, let's say you have to get it to here, get something that's halfway, put it on there, take a break, and move on. But any
A
of those
dolly?
work. Huh?
Another.
A dolly.
Please don't say the joke and not tell me because
It
I'm
was
missing, I'm
no.
missing out.
It's not a joke.
Okay. Very good, group. Very good. All
Very
right.
nice.
Let's do Christy's group because she has to leave early, unfortunately.